Hello, and welcome to Oncology Case Discussions Live. This is our first video of our oncology educational series. Topic: Toxicities of TKIs and checkpoint inhibitors. The aim with this video is to give you a clinical and practical overview of the possible toxicities seen with tyrosine kinase inhibitors and checkpoint inhibitors. My name is Gilbert Morgan. I'm a physician working in medical oncology in Sweden, and you can find this and the rest of our educational videos in our website, in our YouTube channel, our Facebook page, and of course, they will be streamed in our Twitter feeds. You can find mine at Gil Morgan at We Oncologists. Oncology has always been a developing field. The past decade has reawakened an old concept, the concept of immunotherapy. We've all seen this picture. Our oncology house stands on 4 strong pillars. The newest one, immunotherapy, which is not so new, was something that came about in a time where there were no reliable treatments for melanoma and lung cancer. And a lot of immunotherapy trials started, and amazing results surged from this. So now, this modality has been adapted as a primary treatment for some cancers. We're going to talk about 2 specific types: immune checkpoint inhibitors, which are drugs that target checkpoints, which inactivate or activate the start of the immune system, and tyrosine kinase inhibitors, which inhibit or block the enzyme tyrosine kinase. The main thing that we're going to learn here is that the strong 4th pillar of our oncology house, it's here to stay. So it's well worth our while that we learn the toxicities that come from immunotherapy and how to treat them. I won't get into the mechanics, but here are some well-known checkpoint inhibitors. And as we can see, pembrolizumab, nivolumab, Tecentriq, ipilimumab. These are some of the therapies that have become the bread and butter of melanoma and lung cancer. With tyrosine kinase inhibitors, it's the same thing. And these are now being used for the treatment of liver, kidney, leukemias, and yeast. And many have become mainstay therapies. Out of the possible toxicities with checkpoint inhibitors, the main ones that you want to concentrate on is rash, pruritus, liver toxicities, diarrhea and colitis, and hypophysitis. On the right, you can see figure 1, which shows the timing of occurrences of immune-related adverse events. However, this does not correspond to all checkpoint inhibitors, only CTLA-4, and in this specific example, ipilimumab. I just wanted to give you an idea of the timing of when this could be expected. In the graph, we can see that it can all start with a rash, and then you can see the development of diarrhea and the possibility of developing hypophysitis and liver toxicity. Dermatological toxicities with TKIs, mostly affecting the hands and feet, paresthesia, erythema, callus-like blisters, and desquamations. The difference between the dermatological toxicities compared to those from chemotherapy are very small. However, something that can differ between the two is the development of acne and hyperkeratosis. In dealing with dermatological toxicities, this all depends on where you practice, as these dermatological toxicities can be hard to determine. So that's why it's important to be familiar with the grading of the toxicities. These happen in the form of hand-foot syndrome, which occurs early and requires early and close follow-up. In terms of toxicities, you have grade 1, which shows redness, erythema, painless swelling, and paresthesia, in which case you will continue with the TKIs. Grade 2, which shows redness and painful swelling. Grade 3, peeling of the skin, blisters, ulcers, and intense pain. So this is why it's important to know what you're dealing with. And in this case, it's also very good to use the resources you have around you. Almost every patient has a smartphone with a camera, and we are all surrounded by nurses. So do not be afraid to ask your nurses to help you and to have direct contact with your patient. The patient can then take a picture of the skin toxicity, send it to the nurse, and not only do you have a journal of how this is developing, but you can also assess what the patient is dealing with at home and start treatment. In dealing with skin toxicities with checkpoint inhibitors, these normally develop within the first few weeks. Serious toxicities are very rare and do not require reduction or discontinuation. Vitiligo, which is the disappearing of melanocytes, is associated with a good clinical response in anti-PD-1 in melanoma. Rash is something that comes often, as we can see with the use of ipilimumab, 24%, anti-PD-1, 15%. However, a combination of ipilimumab and nivolumab gives you a 40% chance. So how do we treat checkpoint inhibitor skin toxicities? You treat mainly with topical emollients, oral antihistamines, and high-strength topical steroids. Grade 1 to 2 toxicities, you treat with topical steroids. Grade 3, immediate interruption until you go back to grade 1. Systemic corticosteroids between 0.5 to 1 milligram per kilogram. Or in the case of grade 4, you interrupt treatment, admit the patient into the hospital, and you treat with high-dose IV prednisolone between 1 to 2 milligrams per kilogram. So one thing that we will see throughout this presentation is that cortisone is your best friend in dealing with toxicities. This presentation was heavily based on the ESMO guidelines on how to deal with toxicities from checkpoint inhibitors. And the reason I based them on the ESMO guidelines is because I really enjoyed their flow format. These flow charts are very good, not only to determine the kind of toxicities you have in front of you, but also how you're going to go about dealing with them. So I really recommend everyone to download them. They're free from Annals of Oncology or from the ESMO website. And they're a very good tool to have. So we all should have them in our emergency rooms. When dealing with gastrointestinal toxicity and TKIs, we need to give our patients enough advice. Even the simple advice can make a big difference. What to eat and what to avoid. You can tell them to eat white bread, white rice, bananas, avoid spicy food, and reduce fiber intake. In the case of diarrhea, you always want to rule out infectious causes and check if the electrolyte balance is okay. In order to rule out infections, you want to take a C-reactive protein and take procalcitonin. When you're presented with a grade 3 to 4 toxicities, you want to treat with IV hydration and electrolyte repletion. These you want to be very careful because they can be life-threatening situations. To stop the diarrhea, much like with everything else with use loperamide. However, we have to be careful with how much loperamide we are prescribing and how much the patient thinks he or she should take. So GI toxicity with checkpoint inhibitors mostly happen in anti-CTLA-4 monoclonal antibodies. These are including most grade 3 and require discontinuation. We see an incidence of diarrhea in anti-CTLA-4s in 27 to 54%. Colon perforation, this happens in the treatment of melanoma with ipilimumab from 1 to 1.5%. However, in the treatment of renal cell carcinoma, this happens 6.6%. Now you have to bear in mind that colon perforation percentages depend on the dosages that are given. A big factor is the experience of the oncologist that is treating the patient. Watch out if your patient calls you from home, has diarrhea, and you prescribe loperamide. If we have no control over how much they take, we can cause a situation where the patient's flow has stopped, and this causes perforation of the colon. Enterocolitis can occur several months after the last dose of ipilimumab, and although this is incredibly rare, it's just good to know that it happens. GI toxicities with checkpoint inhibitor. What are we checking for? Check your hemoglobin, make sure that there's no anemia. Check your CRP, check for hypoalbuminemia. Do a complete workup, take blood counts, serum electrolytes. In the case of grade 1 to 2, you normally see diarrhea with dehydration, fever, tachycardia, or hematochezia. How do we treat them? Non-severe diarrhea, you can use loperamide, fluids, electrolytes, and continue the CTLA-4. If the diarrhea persists, use a flexible sigmoidoscopy or colonoscopy. Persistent grade 2 or severe toxicities, you discontinue the CTLA-4 and you give systematic corticosteroids, 1 to 2 milligram per kilogram IV. With response after 3 to 5 days, you switch to oral and you taper down over the next 8 to 12 weeks. If your patient does not respond, you treat with infliximab, 5 milligrams per kilogram. Points to remember is that a bloody stool is always grade 3. Make sure that you have ruled out all your differential diagnoses, such as GI infections or tumor-related CRPs. In the case of fatigues, these can happen with TKIs and immune checkpoint inhibitors. We always encourage our patients to follow a routine, keep up with the exercise, and get enough sleep. But by fatigue, I don't mean normal tiredness. An example is when a patient is sitting by the side of his bed and he's too tired to physically move his body to lay down. This can appear suddenly from 1 week to the next. And in this case, do not forget to check the supraadrenals, as it could be an adrenal problem or secondary Addison's. Fatigue is quite so common. It happens 16 to 37% in PD-1, 12 to 24% in PD-L1 immunotherapies. You always want to check the cortisol levels. And if your fatigue is not improved, always consider the dosages of the TKIs. Cardiovascular side effects with TKIs. Our patients can experience hypertension, left ventricular dysfunction, heart failure, and myocardial ischemia. This has especially been seen in sorafenib and sunitinib. If seen, we have to react quickly, evaluate the immediate cardiac situation, take an EKG, and take the cardiac enzymes, postpone therapy until the issue is resolved, and contact a cardiologist. Do not neglect hypertension when using TKIs. This may worsen with certain TKIs, such as the case with sorafenib, and the adjustment of antihypertensive medication will be required. If the patient doesn't have an antihypertensive medication, start them on one, and always recommend reduction of salt intake. We have to be able to know what our limitations are. So if you're not able to control the hypertension, refer the patient to a specialist. Pyrexia, chills, and infusion reactions with checkpoint inhibitors. Often, due to cytokine release and nonspecific activation of an immune response, though this is not always the case. For the management of fever and chills, we use antipyretics, acetaminophen, and NSAIDs. We do this during the infusion and prior to prevent recurrences of infusion reactions. The reason reactions happen until the second infusion is because your body does not have the antibodies when you give the first time. A great way to avoid recurrence of the reaction, it's enough to reduce the flow of the infusion and to give NSAIDs and antihistamines before giving checkpoint inhibitors. In the case of grade 3 infusion reactions, always give the patient antihistamine and corticosteroids IV prior to giving checkpoint inhibitors. Endocrine toxicities with checkpoint inhibitors. Thyroid dysfunction is common with anti-PD-1, PD-L1, or a combo of CTLA-4 and agents blocking PD-1, PD-L1. Typically seen after 2 to 4 infusions. These could be transient, but they can also be permanent. In CTLA-4, we see hypophysitis, hypothyroidism, hyperthyroidism, thyroiditis, and adrenal insufficiency. And here we see that in ipilimumab, 3 milligrams per kilogram, this happens around 1 to 5%. In the case of an increased dose up to 10 milligrams per kilogram, this incidence rises over 10%. So with anti-PD-1, pembrolizumab or nivolumab happens 5 to 10%, but with anti-PD-L1, 5 to 10%. So a combination of ipilimumab, 3 milligrams per kilogram, plus nivolumab, 1 milligram per kilogram, can increase this up to a whopping 20%. This normally comes with nonspecific symptoms, as fatigues and headaches. Hyperthyroiditis in most cases is transient. However, if not transient, check the blood once a week. In many cases, after 3 to 6 weeks, they tend to shift into hypothyroidism. If the patient has a cardiac history, remember to be very generous with beta blockers. Endocrine toxicities with checkpoint inhibitors. Found routinely by checking the TSH and the FT4, which is taken before every infusion. Primary adrenocortical insufficiency. It's treated with lifelong glucocortical replacement. If your patient is hospitalized, take an endocrinology consultation, give the patient IV corticosteroid replacement, and aggressive fluid and electrolyte replacement. With hyperthyroidism, treat with beta blockers in symptomatic cases, and with hypothyroidism, which may develop later, this can be treated by hormone replacement. Normally, it does not get so severe that you see physical symptoms of hypothyroidism. This is because this normally is detected by the blood test TSH, and FT4. In these cases, you will treat with a vaccine, but remember to treat with steroids first. If you don't, you run the risk that the patient can suddenly crash. Type 1 diabetes mellitus with checkpoint inhibitors due to PD-1 and PD-L1 blockade. The PD-1 pathway plays a role in autoimmune diabetes mellitus, so you have to regularly monitor blood glucose level and substitute with insulin. Hypophysitis with checkpoint inhibitors. Inflammation of the anterior lobe of the pituitary gland, as seen. This is mostly in CTLA-4s, very rare in anti-PD-1 and anti-PD-L1. We can see with ipilimumab, 3 milligrams per kilogram, happens around 1%, and 10 milligrams per kilogram happens 16%. A combination of ipilimumab, 3 milligrams per kilogram, and nivolumab increases to 8%. So what we want to do is we want to take an MRI, and in the case of hypophysitis, it will show a swollen and enlarged pituitary. What you have, or what you want to watch out for, is that the patient doesn't have headaches and visual disturbances, and these require immediate evaluation. You want to go through your differential diagnosis, which can be cerebral metastasis, leptomeningeal disease, and cerebrovascular disease. The test that you want to take the prolactin, T4, TSH, LH, FSH, and ACTH, cortisol, and growth hormone. Interrupt if grade 2 or higher, and treat with high-dose steroids and long-term hormone replacement therapy. However, the interruption in treatment is something that has been arguable. One can treat the symptoms with high-dose steroids and continue treatment. The exception to this is the involvement of the optic chiasm. Hepatic toxicities with checkpoint inhibitors. Hepatitis occurs 5 to 10% in patients with ipilimumab, nivolumab, and pembrolizumab. And a combination of ipilimumab at 3 milligrams per kilogram and nivolumab can actually give you a risk between 25 to 30%, with 15% of these being grade 3. Anti-CTLA-4s can have asymptomatic elevations of AST and ALT. Anti-PD-L1 is less often. So one thing we want to test often is serum transaminases and bilirubin, and we want to rule out alcohol, drug, or viral-induced hepatitis. And sometimes the best way to do so is to take a biopsy if we have the possibility. Hepatitis normally resolves itself between 4 to 6 weeks. How do we treat? Well, in grade 2, we increase in transaminase and bilirubin. You're going to withhold the treatment after that and measure 2 times a week. If still elevated after 1 to 2 weeks, you treat with corticosteroids, 1 milligram per kilogram per day, and resume with a CPI after. If no improvement, increase to 2 milligrams per kilogram per day and permanently discontinue your checkpoint inhibitor. Grade 3 to 4, you discontinue your checkpoint inhibitor and you start corticosteroids, 1 to 2 milligrams per kilogram per day, and if no response after 2 to 3 days, you treat with mycophenolate mofetil and consult a hepatologist. Checkpoint inhibitors, immune-related pneumonitis. In anti-PD-1, PD-L1, and rarely with anti-CTLA-4s. Respiratory events are cough and dyspnea. The documentation of pneumonitis is between 2 to 4%, and over grade 3, between 1 to 2%. Discontinuation of treatment due to pneumonitis happens between 0.2 to 4%. The combination of anti-PD-1, PD-L1 with CTLA-4 inhibitors significantly increases the risk of pneumonitis. This tends to occur months after treatment has been initiated. So the things to remember on a clinical setting: remember that dyspnea is not always seen. Examine your patients. Take a saturation after going up a flight of stairs. Sometimes this can come with fever, but so can hepatitis. If your patient calls and has had fever for the last 3 days, invite them to come in for a clinical visit. Treatment of immune-related pneumonitis. We treat with immunosuppressive treatment and should be started immediately. We rule out infections, and if you cannot rule out an infection, treat with broad-spectrum antibiotics. Grade 1 to 2 toxicities: use oral steroids, 1 milligram per kilogram, and assess every 2 to 3 days. Taper steroids over 4 to 6 weeks, and when 10 milligrams of prednisolone, reintroduce the treatment. Grade 3 to 4, hospitalize and treat with high-dose IV corticosteroids. Prednisolone, 2 to 4 milligrams per kilograms per day, and discontinue the immunotherapy. If no image improvement after 2 days, add infliximab, mycophenolate mofetil, or cyclophosphamide, and taper out slowly. Neurologic syndromes with checkpoint inhibitors. Myasthenia gravis in isolated cases in anti-PD-1, PD-L1, and with CTLA-4s. The use of single ipilimumab is associated with transverse myelitis, enteric neuropathy, septic meningitis, and Guillain-Barré. Your diagnostics: you do an MRI and a lumbar puncture. Management: treat with corticosteroids and neuroconsultation. It's possible to treat with IV immunoglobulin or plasmapheresis. The use of plasmapheresis can be argued as well because it removes some of the antibody from the circulation. Some think that it is better to rely on steroids and immunoglobulins in treatment. Remember that a lumbar puncture is the most important part in ruling out an infection such as Borrelia. Ocular toxicity: uveitis in single agent and combination therapies with anti-PD-1 and anti-CTLA-4 or ipilimumab alone. The management: through topical corticosteroid solutions in consultation with ophthalmologists. In the case of grade 3 to 4 toxicities, consider oral corticosteroids. Cardiotoxicities, such as myocarditis, admit the patient and give high-dose prednisolone, 1 to 2 milligrams per kilogram. Cardiac toxicities normally come with arrhythmia. These are hard to detect until the patient is really symptomatic, so consult your cardiologist. Renal toxicities: nephritis, rule out the cause of renal failure and stop all nephrogenic drugs. Interstitial nephritis, seen in single agent anti-PD-1 therapy and combination of nivolumab and ipilimumab. Ipilimumab-related interstitial nephritis may exhibit pathology that is consistent with lupus nephritis or granulomatous nephritis. The clinical course is usually one of asymptomatic, gradually rising creatinine. In treatment, most patients improve with the use of corticosteroids. To diagnose renal toxicities, remember that it's not enough to take creatinine levels. You have to take a urine sediment and consult your nephrologist. In the case of polynephrotic syndrome, you can always do a biopsy. One of the most important things is to review the patient's charts and notice if there has been any rise in creatinine in their history. Pancreatic toxicity, seen as elevations in lipase levels, reported in anti-CTLA-4s and anti-PD-1, PD-L1s, normally asymptomatic laboratory abnormalities. These can be monitored without immunosuppressive therapy. Pancreatitis has been seen infrequently in studies of anti-CTLA-4 and anti-PD-1. And if you have a clinical suspicion of pancreatitis, check the amylase and lipase. Routine assessment of enzymes in asymptomatic patients is not required. So pancreatic toxicity does not happen very often, but it's worth to mention. When it does happen, it's something that every medical student can detect. Classical pancreatitis. Think about the use of steroids. Our take-home message: immunotherapy is here to stay, and much can be treated with cortisone. Many times, a toxicity does not require stopping the treatment. And if you're not sure on the grading, rely on the guidelines when faced with these toxicities. The take-home message is you have to rely on your resources. And for us working in oncology, it's the oncology nurse. They are very familiar with the possible side effects, and they have more contact with the patients than we do. So if you teach them to recognize the side effects of new immunotherapies, what to do in early manifestations, teach them about the grading, they can actually help us come in early and treat the patient in a better way and detect these toxicities as soon as they happen. Another great resource, as I mentioned, is the management of toxicities from immunotherapy by the European Society for Medical Oncology, which is available to download at Annals of Oncology. And with that, I thank you for your attention, and I really hope that you enjoy the rest of our educational videos.